BRCA genes, we know, have a high risk of breast cancer and ovarian cancer associated with them. The risk of breast cancer is about 70%, and the ovarian cancer risk varies from 17 to 44%, the higher one being for BRCA1 and the lower one being for BRCA2. These are potentially preventable cancers. The way we identify people with BRCA genes today, it depends on a strong family history of cancer or fulfilling certain clinical criteria for gene testing. It's also therefore dependent on people getting cancer before we can identify more people at risk. This system is plagued with underutilization and restricted access to gene testing. Despite almost now 30 years of gene testing and knowledge of BRCA genes, most people who have BRCA gene mutations remain unidentified. Our estimate was 97% in London remain unidentified. And this highlights missed opportunities for preventing cancers. An alternative way is to offer testing to everybody. And why not? Why do we need to wait for people to get cancer to prevent other people from getting cancer? Population testing, therefore, offers a route towards this. As part of our research into population testing, one of the things we've done is evaluate cost effectiveness or do a health economic evaluation across multiple countries and health systems of one, whether this would be cost effective to do, and two, what is the potential impact we would see if this was instituted. Any new intervention requires some sort of an economic analysis which weighs up the costs and consequences. If something is not economically sustainable, it can't be implemented and sustained. So in our analysis, we have undertaken what's called MRCOG modeling, which is a standard form of cost effectiveness analysis, looking at all the costs and consequences. The consequences are evaluated in terms of quality adjusted life years. These are weighed up against the various thresholds at which health systems would consider new interventions. And these thresholds are well described for some countries, particularly in high-income countries. And we've used UK, US, and Netherlands as examples. In the upper middle-income countries, we have used China and Brazil as an example. And in the lower middle-income country, we've used India as an example. Where these are not well defined by country-specific health system, the WHO has guidelines on this. And the analysis we present is both using WHO guidelines for all countries and also using country-specific guidelines where they exist. Our analysis suggests that population-based BRCA testing would be cost-effective in high-income countries. If we look at it from a payer perspective, there are two ways to do cost effectiveness analysis. One is a health system of payer perspective, which is what, for example, the UK advocates or is looked at by NICE. And the other one is societal perspective, which is advocated by, say, the WHO or other countries. Some countries look at both. So what we've done in our analysis is present all the data so that people can draw inferences. And we find that from a payer perspective, it's extremely cost effective to do population-based BRCA testing. And you will end up saving more lives and at a value which the health system would normally prescribe to a new intervention. If you look at it from a societal perspective, it's actually cost saving. So you would actually save both money and lives. In upper middle income countries, you find that it's cost effective. So in China and in Brazil, it would be cost effective. In lower middle income countries, you find that for the base case scenario and using the cost of the test that we use, which is $200, it would not at present be cost effective. But as the cost of the test falls and we plot the change in cost of testing versus the outcome or the cost effectiveness of this intervention, as it falls to say $172, could potentially become cost effective from a societal perspective, and I think it's about $90 from a payer perspective. So two things are happening. One is the cost of testing is falling to our ability to do high throughput, large volume testing is now technically there. So it offers the opportunity, I think, to do population testing, and what is required is implementation studies, large-scale implementation studies to develop country-specific models or health system-specific models or region-specific or context-specific models to take this work forward and try and change policy for the future. Uh, Clearly, we can prevent a huge tens of thousands or hundreds of thousands more cancers depending on the population of the country compared to the current policy. Also, I think it can give a fillip to testing because it hopefully increase utilization of testing. And currently, we have restricted access and utilization in most parts of the world. So this does have potential global implications for what I call precision prevention, and can prevent many more breast and ovarian cancers in the current policy. It also sets the scene for using this sort of intervention as the work progresses to look at other cancer genes and for that matter, become a way of preventing other chronic diseases for the future. So I think it's important, exciting work, and will hopefully pave the way for much more research to follow.